We just have him online. Good afternoon, sir.
Hello.
Welcome you to.
Hello, can you hear me?
Yeah, we can hear you, sir. We Please load your presentation so that we can see. Yeah.
Yes. So, thank you very much. It's a great pleasure to see all of you, and thank you for accommodating my talk online. I would have absolutely loved to come, but I'm at the moment not in a condition to travel. So, I will, no, the host has disabled my screen sharing. So, can you ask the host to
Yeah, sure.
allow me to share the
Can
screen?
you enable sir to share his screen? It has. They are doing it. Just
Yeah.
okay. I think you can
Yes.
now able to share your screen.
Yes. So, can you see my slide?
Yes, sir. We can see your slide and we can hear you well as well. Please go ahead.
Okay, so thank you very much. Again, a real pleasure, and my sincere thanks to the organizers and my good friend, Dr. Ashish. So I'll talk about modular stems in revision and also their specific advantages, their role, and when you can possibly use non-modular stems and what are the precautions that you need to take. So, what is the need for modularity? One, of course, is easy to understand. That's the absence of anatomical landmarks, and obviously, it's to recover, to overcome bone loss. But I think really the most important advantage of a modular stem is to address metaphysio-diaphysial mismatch. And we all know the disadvantages of a pure diaphysial fixation in a revision scenario, because what happens then is stress shielding of the metaphysis and the bone just disappears. And I will show you x-rays what happens when that is the situation. So that's why, so the other advantages are just corollaries. You know, you achieve stability in axial and rotational planes, and you get both proximal and distal anchorage, which are very important. Now, this paper by Cameron in 2002, it talks about the advantages of modular femoral components in revision. That's, like I said, the most important thing is it avoids it addresses metaphysio-diaphysial mismatch. And in order to be able to do that, you do not need to do excessive diaphysial reaming just to make it wide enough to accommodate a non-modular stem with a wide metaphysis. So it prevents metaphyseal stress shielding, and of course, it obviates the use of allografts. And only when there is a completely disorganized metaphysis that these stems do not have a role. So clinical outcomes over the years, they've always had extremely good survivorship, more than excess of 90% in several papers. Now, when you approach a revision THR for femoral reconstruction, so you have an option. You can either go for a modular or a non-modular fixation, and if you have to depend on pure distal fixation, then you have the conical and cylindrical offset. You have nowadays the fully coated HA stem, which osteointegrates both proximally and distally, and perhaps a little more protective of long-term implant failure. And then I'll just mention about the other technique which is now increasingly getting lost upon us, that is the impaction bone grafting and cemented reconstruction, which is a very good way of reconstructing lost bone. Now, why is proximal fixation important? Simply because it restores bone in the proximal femur by Wolff's law, and it prevents stress shielding of the metaphysis and preserves distal bone for future revision. These are the advantages of proximal fixation, which can be achieved in a modular implant. Now, this is clinically proven. Bone grafts are usually not required in this method. Provides and this is, I think, the most important sentence, that it provides independent hold of metaphysis and diaphysis, and you can actually link the two. And we have already seen the advantages of avoiding stress shielding. Now, the problem of proximal fixation in revision scenario is that you have a very poor proximal quality of bone, and usually there's a very wide metaphysis and a very narrow diaphysis. So you either have to use a narrow stem which is loose in the metaphysis, or you have to excessively ream the diaphysis You might actually cause a fracture if you're trying to put in a tight-fitting stem. So malalignment between the proximal and distal femur due to varus molding, which is again very commonly encountered in revision scenarios. So one of the stems which I like to use to address these difficulties is the S-ROM, and you have a variable rotational stability from the sleeve. So this gives you a modularity in version, and which is a very, very important thing. As was apparent in two of the previous lectures, one was the one on DDH, where I think this is the stem of choice, and the other is when you have a spinopelvic uh, uh, discrepancy, that's also where you can actually address the version. Then you have the anti-shrinkage support from the sleeve and axial support from the stem, which is fluted and it is pronged, so it actually holds on to the diaphysis at least until the sleeve osteointegrates. You have good temporary stability in the diaphysis. So when we look at, let us look at some examples. The Paprosky 1 and 2 are really typical cases for modular uh, stem fixation. This is an example, as you can see, with loss of diaphyseal bone. It's been addressed with a wide sleeve and a tightly fitting diaphysis. And in the S-ROM, you have the modularity in the armamentarium to link the sleeve with the stem. Yet another example here of diaphyseal bone loss, and again addressed. As you can see, the diaphyseal bone loss did not need to be grafted. The sleeve fitted very well, and then the stem sort of uh, complemented the fixation. A very common scenario which all of us face, I think, in our practice in India, the failure of fixations of proximal femur. Usually, sometimes the implants are to blame, and here again, this has been addressed very adequately with a modular stem with a good metaphyseal fixation. And you can see in this X-ray how nicely the metaphyseal bone has been restored. Now, the Paprosky types 3 and 4 are a little more difficult because the proximal bone loss is quite a lot, but still, many of these can be actually addressed. And this is an example where there is a loosening in a cemented stem. As you can see, very poor proximal femoral condition. This is what I was talking about, the varus molding, and this needed an osteotomy to correct that. Excuse me. And then that needed additional wiring, of course, but it was fairly reasonably addressed with this S-ROM type of a stem with both metaphyseal and diaphyseal fixation. Here again, you see an implant which is sort of penetrated and perforated through the cortex, and again addressed without the need for bone grafting after removal of all the cement with a very good. You see how nicely the sleeve sits, and this sleeve is porous coated, and it osteointegrates with the metaphysis. It loads the metaphysis, and this patient will come back with very good metaphyseal bone. Yet another example, you have severe osteolysis in multiple Gruen zones. This is a Paprosky 4, again addressed with the sleeve fixation of the metaphysis and diaphyseal fixation with the stem. Again, a very common scenario in our practice here, the loose Thompson's prosthesis, which was very widely in use in the past, again addressed with the modular long stem, and of course this required their stabular exchange as well. We accepted a high hip center because the bone quality there was very good. So it's not without its complications, and especially when you use a long stem, you can get distal fractures, particularly of the anterior femoral cortex, and you can get also trochanteric fixation failures with subsequent loosening and subsidence of the stem. Now, to address this, it may be a situation where you might want to use fully coated modular stems. And here you see the osteointegration is achieved right through the length of the stem, so it prevents subsidence and it prevents stress shielding by loading the metaphysis. And again, several studies are there, some of which I have noted down here, which have shown extremely good results. So this is one of the systems which are available. This is the reef, where you see it's a completely modular system. where you have version modularity, you have options to attach the abductor muscles with the trochanteric plate, and you have two distally locking screws, though they are a little bit cumbersome, I find. So there's a trochanteric component, there's an optional lateral wing, the distal and the proximal stems are different, so you can actually, again, select them separately, interlocking screws for further fixation. And this is an example, again, you see loosening of an implant. We had to do an ETO here, extended trochanteric osteotomy, which had to be wired, and this was fixed with the reef system adequately. Again, a broken implant, the HTO had to be done for moving the components, and well, somewhat difficult situation, but here we managed to get away without, after having to wire the osteotomy. So coming to the distally fixed modular stems, this is recommended in cases with extensive proximal femoral bone loss. But here, actually, most of the time you will be forced to use non-modular stems, and here it requires at least 4 centimeters of diaphyseal bone. Femoral straightening osteotomy may be necessary, and proximal femoral augmentation with allografts if you have access to a good bone bank. But a multicentric retrospective analysis here shows a very good survivorship in these non-modular stems, as is shown in this example. What I have to say here is that there are two kinds of non-modular stems, the conical and the cylindrical. The conical titanium stems of the Wagner type have given consistently good results in literature, and as you can see here, the metaphysis is far too wasted to actually provide any sort of fixation. The fixation is purely distal, but if you have a conically fitting titanium stem, then this generally is very reliable. This is a conical stem which has been used, uh, but again, this is actually a somewhat a critical situation, because this can fail. As you can see, there is nothing in the metaphysis holding on to the plate. And this is an example where this sort of pure distal fixation has failed. As you can see, the stem is broken. This is the broken stem which has been removed, and this kind of cylindrical cobalt chrome stem is somewhat prone for breakage. So this stem should be used only if you can reconstruct the metaphyseal bone and have some sort of metaphyseal fixation. A purely diaphyseal fixing situation in this will actually not succeed. And again, this had to be revised using the reef system, where we got reasonably good metaphyseal hold. You see, the stepped metaphyseal geometry sort of gives a good metaphyseal loading, and this patient can come back with a lot of new bone formation. So just a slide on this, a collarless polished stem or even a collared stem have been used in impaction grafting. Here, of course, this is a technique which is somewhat has lost its popularity, but it's a very good way. If you have a bone graft, it's a very good way of reconstituting the lost bone. It demands very meticulous technique, and what excellent results have been reported in several studies, and particularly the Swedes, the Swedish registry. They are very wide users of this technique, and they have consistently reported very good results. So this is an example. We have here the isoelastic hip, which had a disastrous history, and this had to be revised with, and we have done it with impaction bone grafting and an Exeter stem, which is ideally suited for this particular procedure. So I think we'll skip this slide, because sometimes you might have to do this, modular megaprosthesis, when there's too much bone loss. The problem here is that the survivorship is not very, very high, and therefore it's just about 73%, so high dislocation rates. So they're probably okay in very elderly patients, but otherwise, I think the young patient is probably to be used with extreme caution. So in summary, femoral bone defects and deformities are very frequently encountered in the revision scenario, and there's a loss of anatomical landmarks, which is where your version modularity particularly comes in very, very useful. A modular femoral component provides satisfactory ways to get both metaphysio-diaphyseal fixation and link the two adequately. Of course, the selection of the implant depends on the extent of bone loss. You might want to go in for a pure distal fixing stem if you have too much bone loss. And the big advantage of the modularity is that you don't really need, you very seldom actually need to use bone grafts. So I bring you greetings from Kolkata. I would have absolutely loved to be in Patna with all of you people next time, perhaps. And thank you very much for a patient hearing.
Thank you very much, sir, for excellent, excellent talk, and we'll love to see you in person here. And
Thank you, sir, for coming to
yeah,
AMC.
Ashish, yes.
Yes, no, and thank you, sir, for coming to AMC virtually. I'm sorry that you have a sore back. So
Yeah.
please keep logged in on the AMC website so you can see the live surgery now. So may I invite
Yes.
Ashok sir to kindly felicitate Dr. Sudeep, sir?
And we'll thank all the speaker for this session. Two speaker left will be, I think the live surgery is on, so they will be speaking after the live surgery is over. Thank you all. Thank you.